What's up, Ninja Nerds? In this video today, we're going to be talking about deep neck infections. And again, this is a part of our clinical medicine series, and we're going to kind of dive deep, no pun intended, into the different types of infections, such as things like a parapharyngeal abscess, a retropharyngeal abscess, a peritonsillar abscess, and we'll talk about something called Ludwig's angina, which is technically not an abscess, but we'll get into that. And if you guys are digging these videos, they're helping you, they make sense, then support us. Hit the like button, comment down in the comment section, subscribe, tell a friend. Also, I really suggest going down in the description box below, clicking on the link that goes to our website and get some access. Become a member and have access to things like notes, illustrations, quizzes. We're developing flashcards. There's a lot that I think allows for the application of all this information, which is critical to learning. Nonetheless, let's talk about learning. Learning what? Deep neck infection. So when we talk about these, there's obviously a bunch of different deep neck spaces, and I don't want to go absolutely ham bone on anatomy. That's what anatomy is for. We're going to do a little bit of a quick reminder on specific components here. So imagine here, I'm taking a look at someone's, primarily their throat and the deep neck spaces around it. So essentially how I want you to imagine it is, imagine I'm taking like a slice, like I'm just getting cut right in half, and I'm going to slice through and I'm going to look at this kind of like axial section, if you will. And so what you'll see is you'll see here is going to be kind of parts of like the pharynx, like lumen. Here would kind of, you could imagine, here's the tongue, and you'll have some teeth over here. But there's a couple different components here. The first thing is here in pink, we have these structures called the tonsils, right? So that's your tonsils. So here we'll have some tonsils. And the next component here is that we're going to have some arches. And so I won't label these, but again, you have this arch here, which is going to form like the anterior tonsillar pillar. This is called the palatoglossal arch, and there's a muscle in there called the palatoglossus. Then there's this structure here in the back. And this is another, this forms the posterior tonsillar pillar or arch, and we call this the palatopharyngeal arch. And there's a muscle in there called the palatopharyngeus. The tonsils, just behind them, there is this white space. Do you see this white space here? This is called the peritonsillar space. I'm going to write that down. This is called your peritonsillar space. And essentially what it is it's just going to be this little piece here just behind the tonsils and in front of this muscle here, this red strip of muscle. What's that red strip of muscle? That red strip of muscle right here is called the superior pharyngeal constrictor. So the superior pharyngeal constrictor. So far we have the tonsils right here on both sides, the palatine tonsils. They're sitting in the fossa, the tonsillar fossa formed by the arches and the muscles. There's a space just behind it called the peritonsillar space, and just behind that is a superior pharyngeal constrictor. All right, so we're going somewhere. All right, the next thing is in the back here, you would have this little, this little speed bag in the back of your throat. What's that called? That's called the uvula, right? So you technically have this thing here called the uvula. And then if we wanted to, this would be the back of the throat. So this would be the back, the posterior wall of the pharynx. This black line here would be the posterior wall of the pharynx, if you really wanted to think about it like that, right? All right, so we're going somewhere. Next part is we are going to go into this next area here. Here, this is actually going to be the mandible. So right here, this is going to be what's called your mandible. And then you're going to have some muscles. This one technically is called the masseter. And then this one here on the other side is called the medial pterygoid. Then here you have the parotid. And then here you have what's called the styloid process, the black structure. This little black circle is the bone, the styloid process, right? And then there's a bunch of muscles around it, like the stylopharyngeus, stylohyoid, right? And so all of those muscles are definitely around the styloid process. The next thing is you have this thing called the carotid sheath. We're not going to go into the contents of it just yet. We will a little bit later, but this is called the carotid sheath, and inside of that there is the carotid artery, there's the jugular vein, there's some nerves like cranial nerves, etc. The next thing that I want you to know is we've already talked about one space, and this is the peritonsillar space. That is where certain types of infections can form and organize and lead to a peritonsillar abscess, right? The second space is kind of like, I'm going to do something where I'm going to create like a dotted line. This styloid process is a landmark. And what that does is it breaks this space up into like two areas, like two subspaces, if you will, right? And so this here, which I'm going to kind of point in here, I'm going to kind of do it, I'm going to shade it. I'm going to shade all this area here in blue. And then the space posterior to the styloid process, we're going to highlight in this pinkish color. All right, so this is going to be it's technically one whole space, but it's subdivided based upon the styloid process. What are these two spaces? We have essentially kind of separated this into two spaces. Let me kind of show you what I mean. If I come over here, I'm going to do where we can kind of have this here, and then we're going to have this kind of go across. We create these two little compartments. This is called the posterior parapharyngeal space. Some people call it the, like when you kind of look at this, it's like it's behind the styloid process, so they call it the post-styloid parapharyngeal space. I just like to call it the posterior. Essentially, this is the part that is in the compartment behind the styloid process. And then if it's the one that's actually in front of the styloid process, it's called the anterior parapharyngeal space. So far we've color coordinated the parapharyngeal space. We should do that for the peritonsillar. Peritonsillar, let's make orange. So again, peritonsillar space is kind of this orange space right here, if you will. Okay, so there's the peritonsillar space. So far we've talked about the peritonsillar space. We've talked about the parapharyngeal space. What's the next one? Well, the next component here is we have, again, I told you that there is this posterior part of the pharyngeal wall, then you have the superior pharyngeal constrictor muscle, and then you have this next black line. The next black line that we're going to have right here is called the buccopharyngeal fascia. So it's the buccopharyngeal fascia. So that is going to be this part right here. The space between the buccopharyngeal fascia and this pink line, what's the pink line called? The pink line is called the alar fascia. Fascia, right? So it's the alar fascia, which is this pink structure. And then if you wanted one more, there's this blue one, and that is called the prevertebral fascia. Well, we create spaces, right? So we talked about the peritonsillar space, which is the space between, right behind the tonsillar capsule and the superior pharyngeal constrictor. The parapharyngeal space, we said, is two compartments. It's the posterior parapharyngeal space, which contains things like the carotid sheath, and it's behind the styloid process. And then the anterior parapharyngeal space, which is just going to be anterior to the styloid process. The retropharyngeal space sits between the buccopharyngeal fascia and the alar fascia. So what color should we pick for that one? Let's do that one in this purplish color. I think that'll work. So here I'm going to fill all of this space in right here. This is your retropharyngeal space. That is your retropharyngeal space. Let's actually write that one out there. So retropharyngeal space, because we're getting close on the tightness here, is this here, this space right here to here. This is called your retropharyngeal space. All right, so I have to red square that up. And the reason why is I have to get you guys oriented to a degree to somewhat of the anatomy, because the infections occur in those spaces. So when we talk about peritonsillar abscess, it's a collection of pus. This is a collection of pus. This is a collection of pus. And again, I needed you to understand the definition. You have to understand the anatomy. So it's a collection of pus where? In the peritonsillar space. And then if some anatomist or some surgeon came and said, hey, Zach, explain to me where the peritonsillar space is, you could say, oh, it's the space just behind the capsule of the tonsils and in between the superior pharyngeal constrictor muscle. Oh, good deal. Okay. Parapharyngeal abscess. This is a collection of pus in the parapharyngeal space. But then you could have a really particular surgeon or anatomist that would say, hey Zach, explain to me where that collection of pus is, the parapharyngeal space. You would then say, okay, all right, doc. So what it is you have to think it's beyond the superior pharyngeal constrictor muscle, and it's into this area. And how we divide it is it's based upon the styloid process. The styloid process has a space, a triangular space, that is filled with fat and muscle and lymph nodes, and that's called the anterior parapharyngeal space. Pus can collect there. The other one is the posterior pharyngeal space, so it's just posterior to the styloid process, and that contains a very critical structure called the carotid sheath. You're getting to the point of why this is so critical, because once we start talking about the reasons for these things, how these actual things cause mass effect, how these things cause scary complications, we'll get it because we've gotten down the anatomy. The retropharyngeal abscess. This is a critical one because it's a collection of pus in the retropharyngeal space. And again, you're probably like, dude, do you really need to write that? No, I don't, but what I would then say is explain to me, if you could, where this actual abscess is. It's in the posterior portion of the pharynx, between this black line, the buccopharyngeal fascia, and this pink line, the alar fascia. That is the retropharyngeal space. And again, the reason why I mention these things in these fascias is I didn't get into this next one, which I'll talk about a little bit later. There's another space, which is between the pink one and the blue one. And it's called, I'm gonna write it in here for now, I just want you to trust me, it is called the danger space. It's super ominous, and it should be ominous because it is a terrifying space. But the reason why I say all of these things is, when you think about a peritonsillar abscess, it's a tiny little space. Tiny little space. When you think about a parapharyngeal abscess, dude, that's an infection that could really wreak havoc on vascular structures and muscles. This one here can get into the danger space. Why is the danger space so dangerous? We'll talk about it. It connects to your mediastinum. If I had pus going to my mediastinum, I could cause mediastinitis. That's dangerous. So that's why I'm kind of getting you guys to understand the anatomy. All right, cool. We talked about peritonsillar, anterior parapharyngeal, posterior parapharyngeal, and the retropharyngeal space, and then its connection, how close it is to this thing called the danger space. There's one more, and this is called Ludwig's angina. Ludwig's angina, we do have to understand a little bit of anatomy here. So here we're gonna have the tongue, right? So here's our tongue, and there's a bunch of different intrinsic muscles of the tongue. And then on top of that, there is kind of another kind of muscle just here at the base, and we call this one, the genioglossus. And then there's one more. So here we have what's called the hyoid bone. So the hyoid bone is our kind of like our reference point for this. The hyoid bone. And there's two muscles that come here that form these like spaces. This one comes up here, and it's going to connect to the mandible, right? But we call this one here, this is called the geniohyoid. I'm gonna draw it back here. This is called the geniohyoid, right? And that is going to be this muscle belly right here. Then you're going to have another muscle belly, which is going to be this one, going here, and again, going to the mandible. What's this one called here? I'm going to draw this one backwards. This one is called the mylohyoid. The mylohyoid is your reference point. The mylohyoid is really going to be the line in the sand that creates two spaces. Here is a space here, and it's between what? The geniohyoid and the mylohyoid. There's a space there. Then there's like fascia, which is this orange thing. It kind of controls the limitation, but there's another space just beneath the mylohyoid and then the actual fascia. Do you guys know what that's called? All right, let me explain here. There's two spaces, and these are important because these two spaces get filled with infected material. This one here is called the sublingual space. And this one here below the mylohyoid is called the submaxillary space. These two spaces, we say, makes up, and I know it sounds dumb, but these two spaces make up what's called your submandibular space. So these make up your submandibular space. What happens is in patients who get Ludwig's angina is they get cellulitis, a necrotizing cellulitis, not pus. All right, so that's the key thing. It's necrotizing cellulitis of the submandibular space. So that's why I really kind of talk to you guys about this, is Ludwig's angina is really, it's not a collection of pus. It is a, son of a gun. It is a necrotizing cellulitis, not pus, of the submandibular space. And if someone said to you, oh, Zach, okay, well, where's the submandibular space? It is technically a sublingual and submaxillary space that is formed by a line in the sand called the mylohyoid muscle. So infection can accumulate in the sublingual space, and infection can accumulate in the submaxillary space. Here's what we'll get into when we get into these. These are controlled. Like what's restricting this thing above? The dang tongue. What's restricting this thing from actually moving below? The fascia. These infections, when they get bad, they cause swelling and they got nowhere to go. And that becomes really, really dangerous. This is one where I want you guys to understand that this Ludwig's angina is not a pus collection, it's a necrotizing cellulitis. And that's a different component between these, all right? So we've really taken some time, I think, to get the anatomy down. I got peritonsillar abscess, infection of the peritonsillar space, which we talked about. Parapharyngeal abscess, infection of the parapharyngeal space. Retropharyngeal abscess, infection of the retropharyngeal space. And I got it down the anatomy, right? I'm pretty good with that, and it's pus collections. Ludwig's is a necrotizing cellulitis of the submandibular space, which is made up of these two spaces. What I want you guys to then start to think about is when a patient has something like a deep neck infection, what would make me think of this in general? Well, there's a lot of things that cause deep neck infections, and we'll get into that with each individual deep neck infection. But oftentimes there's a couple characteristic signs that are pretty standard across the board. Well, one of the things that I want you guys to think about is that there's an infection and pus in all of these areas, and it's usually in the mouth or it's near the throat. So one of the classic kind of features I would say is you're probably gonna have a patient with some degree of like a sore throat, or we could even say some degree of like the floor of the mouth is gonna be really, really sore. So they're probably gonna have some type of throat pain, we could say, or we could even say maybe like mouth pain. And that would be the exception for which one more particularly? Probably for the Ludwig's angina. You'd probably have more pain there on the base of the floor of the mouth. Whereas all of those there with a patient who has peritonsillar, retropharyngeal, parapharyngeal, it's gonna be more involving the throat. So you get what I'm saying there? So that's gonna be because of inflammation of those tissue areas. The second one is, with this, a patient may also have, and this is kind of interesting, they may have drooling. So there may be some degree of drooling. And I want you to think about this. If you have a lot of swelling and it's so much pain that it's difficult for you to swallow, what happens if you can't swallow those secretions? They pool up. And so this is due to inflammation of those tissues. This is probably due to what concept that I want you guys to add on just to your repertoire to understand why they're drooling, is because the difficulty with swallowing, because it's painful, so dinophagia, swallowing causes a buildup. It causes pooling of secretions, right? So that's something else I would want you guys to add on here. So that difficulty with swallowing is going to cause that pooling of secretions. So that's another one. The third component that is also critical here is that the patient will probably have some degree of a muffled or hot potato voice, we call it. So you ever taken and eaten something like, you know, usually if you have something in your mouth, it's difficult to speak, and so it muffles, you have a muffled voice. This is actually pretty simple. So muffled, and we sometimes use this term that you may see on the exams, hot potato voice. So it sounds like something is in their mouth. The concept behind this is pretty straightforward. Think about this for a second. You have all of this swelling that is inside of like the pharynx or around the tonsils or in the base of the tongue. All of these things are doing what to this lumen? they're narrowing it. When you produce sound, sound waves are supposed to be generated from the larynx, and they'll run across your vocal cords. They'll produce that sound, and then what happens is it runs through your mouth, it runs through the nasal cavity, through the sinuses, and it's supposed to help with the resonance of sound. If you have things that are obstructing the resonance, that's going to cause the muffling of the voice. So what happens here is this is due to a decreased resonance of sound. And that's what I want you to understand, is decreased resonance, which is basically whenever those sound waves are being produced by your vocal cords and they run through these areas to gain resonance, to make your speech become clear, there is something that is obstructing that kind of sound resonance. And that is a critical thing here. The last thing is that actually pretty much all of these infections are bacterial in origin. Bacterial infections oftentimes produce more systemic inflammatory responses, enough that a patient will have some degree of a systemic inflammatory response, and one of the ways that we determine that is the presence of a fever. So this fever is likely due to what? It's likely going to cause the patient to be, usually it's guaranteed greater than 38 degrees centigrade, but it's likely due to bacterial infection. And that bacterial infection is causing a more intense inflammatory response. I hope that makes sense. Okay, so if I have a patient comes into the hospital, they come into the clinic, they come into the otolaryngologist and they say, man, I've been having something, and they would probably have a hard time. I'm having a sore throat, it's difficult to swallow. You notice that they're drooling, they have lots of secretions pooling up. Their voice sounds muffled, almost as if they were talking with a hot potato in their mouth, and they got a fever. You're gonna be like, oh crap, okay, could this be an infection somewhere within the neck and the deep neck spaces? Then you gotta start looking around, and we'll get into what we should be looking for to say, oh, I think it's this one over this one, or this one over this one. That's where anatomy and also just a good physical exam comes into play, and history. The thing I want you guys to understand, because we'll get into it in a little bit later, is that with these infections, the reason why they're so critical for us to be able to ID them quickly and efficiently is because of the risk of complications. I'll get into them and I'm going to talk about them now. But one of the big things here is with things like, for example, we talked about these, and I'm going to abbreviate them, a parapharyngeal abscess. What's in that space? I told you what's in that space. It's really, really an important one. You have to remember that. It's the carotid sheath. So the feared complication of this is if we don't take care of it, it can invade the carotid sheath. And that can cause some terrifying types of presentations. So that's what we get worried about here, because in the carotid sheath is the carotid artery, there is the internal jugular vein, there's cranial nerves. We don't get that infection to treat properly, they could have that kind of problems where they could have vascular and neurological complications. Second one is the retropharyngeal space. The retropharyngeal space, I told you, there is a space just posterior to it. As the danger space, right? The danger space is dangerous because what does it connect to? The mediastinum. So we'll talk a little bit later, but mediastinitis. Mediastinitis is just the absolute, I think I got a lot of T's and I's in there. Mediastinitis, oh, I got it, all right. Mediastinitis. That there is the really concerning feature of a retropharyngeal abscess. And the third one is the Ludwig's. Now, Ludwig's is terrifying because if you think about this, if you get an infection here and it starts to swell, it pushes the tongue back posteriorly and upwards, and then it pushes all the soft tissue structures of the neck backwards. I'm gonna obstruct my airway, and if I have so much swelling, I can't even stick a tube down their airway. So the most concerning feature for Ludwig angina is it can become a respiratory emergency. And that is because it can lead to almost complete, near, or total airway obstruction, which can cause asphyxiation. And I think that would be a terrible, terrible way for a patient to die. So that is why we need to be able to identify these. The reason why I mention these now is in these patients, when they come in with this, if you see carotid sheath invasion, I want you to think when we talk about it, oh, that'll have a patient who has something wrong with their IJ, something wrong with the carotid, something wrong with the cranial nerves. If they have a retropharyngeal abscess, you want to start thinking about things. Could they have infection of their mediastinum? What does that look like? If they have Ludwig's, I need to know that what is the most important thing to do for this patient? Secure their airway. So that's why I wanted to take some time, because now what I want to do is we have the general presentation. We have the optimal fears of what can happen if we don't get to this and treat it appropriately. We know a little bit about the anatomy and the different types. Let's dig into each one just a little bit more. All right, so let's start off first and foremost with the peritonsillar abscess. We know it's an infection of the peritonsillar space. Now, the question that you have to start thinking about is what causes this? There's a, it really comes down to, I'd say most often, we talked about this in the tonsillopharyngitis lecture, is for the most part, it's gonna be some type of group A strep. That's really the key trigger. So it's oftentimes gonna be a patient who develops a group A strep tonsillopharyngitis. And that's really it. And maybe it just wasn't treated. Maybe it just got really, really nasty. Either way, that's the trigger. So here we got our pathogen. We have the responsible trigger, the etiological component here. And that's this nasty son of a gun, the Streptococcus pyogenes, or the group A strep. What happens is that obviously this is going to trigger what? It's going to get here in the tonsils and it's going to cause inflammation. It gets trapped in the tonsillar crypts. You get an inflammatory reaction here. And generally in most people, if you treat them with antibiotics, you treat it acutely or quickly enough, you can clear it. But what happens if that infection from the tonsil starts spreading and breaking past the tonsillar capsule? And as it gets into the tonsillar capsule, you break into this peritonsillar space. And it starts to fill and fill and fill this peritonsillar space with pus. Well, then now, my friends, you have a peritonsillar abscess. What's the problem with that? All right, I know it's going to cause throat pain. I know because there's an infection, a bacterial in origin, it's going to potentially cause a fever. I know that if it's really painful to swallow, they'll accumulate their secretions. I know that they may have a muffled hot potato voice. But what else is really the problem with here? I'll tell you a couple things. One of the concepts here is that you're going to have two pathophysiological responses. One is going to be a mass effect problem, and the other one is going to be a tissue invasion. So one is going to be due to mass effect. So that pus is going to cause mass effect and push things out of the way. All right? Let me explain that one first. So imagine here that this pus continues to accumulate and accumulate in this space. What's that going to do? Well, here, let's pretend I have all this pus accumulating in this space. What it's going to do is it's going to start bulging things. This thing is going to accumulate and it's going to start swelling enough that you're going to notice that the tonsils are going to be pushed forward so much, and on top of that, the uvula is going to be, muffin caps are going to be bent that way, right? So what you're going to notice from this mass effect here is that this tonsil is going to have all of this kind of thing behind it, all this pressure being generated behind it. And because of that, all of this pus, all of this material, this infected material, is going to have a mass effect here in the peritonsillar space. And what is it going to do? It's going to bulge the tonsil out and it's going to push the uvula to the contralateral side. So two things happen as a result of that abscess. One is I bounce that tonsil out and I bounce the uvula to the other side. So you'll have tonsillar swelling, and it's going to be the affected side. Tonsillar. It may look like in this scenario it's bilateral, it's not, it's just one side. So tonsillar, swelling, and then uvula deviation, and it's going to be to the contralateral side. The reason why I tell you this is when you take a look in a patient's mouth who comes in with a sore throat, a fever, hot potato, or muffled voice, some drooling, you look in, you see the tonsils bulging out, and on top of that, the uvula is deviated, you start to think it could be a peritonsillar abscess. But let me add one more. I told you that this was what structure here? This was the mandible. And there is a muscle that's just right here. All they have to do is that infection can get just a little bit out right here. What was this muscle called? The medial pterygoid. This is an important muscle. It's one of those mastication muscles. What if an infection from here kind of just was able to get over here and irritate? Or you get enough inflammation, whatever it is, enough inflammation that it causes irritation of the medial pterygoid. So one thing is I'm going to get irritation And it could be because of just local mass effect. It could be because the infection is breaking through and getting into this space. It's oftentimes maybe a combination of both, but irritation of the medial pterygoid. What will that do? This is a really good thing to remember. Whenever you're medial pterygoid, it's helpful for helping to kind of open up the jaw. This thing is going to be spasming. And you're going to try to open up the jaw and it's going to hurt so bad. And so they have inability to open the jaw. What's that called? What's that called when you have inability to open the jaw even a little bit because this muscle spasm and it's contracted down? That is called, it's not called lockjaw, you would think it, we call it trismus. So it's called trismus. And that's basically, in other words, it is in fancy terms, inability to open the mouth. Even a little bit, like 2 centimeters or so. And that is because either the mass effect or the infection has started to cause irritation of what muscle? This muscle here, the medial pterygoid. Either it's due to mass effect or it's due to invasion into that area. By the time it invades into that area, the problem is you're kind of getting into the parapharyngeal spaces. Parapharyngeal abscesses tend to have the most severe types of trismus, but you can see trismus in patients who have peritonsillar abscess. So to recap this one, with peritonsillar abscess, patient comes in, muffled voice, they have a fever, they have a sore throat, they have drooling, you look in their mouth, you see the uvula is just fucking ping pong into one side, the uvula is ping pong into the other side, they're having difficulty opening their mouth. That would be something you would think about with a peritonsillar abscess. What's oftentimes the story? It's a child who ended up having a strep throat. Maybe they didn't get treated or they weren't adequately treated and all of a sudden they have this fluctuant abscess. That is what I want you to take away from this one. All right, cool. That's it. Parapharyngeal abscesses are a little bit more of a different story though. The problem with the parapharyngeal abscess is that these things, it kind of depends. The trigger, it differs. So for example, what do I mean? Well, etiology-wise, it could be 2 things. One is it could be a patient who had a peritonsillar abscess and it spread. So for example, you could have a group A strep tonsillopharyngitis. This is common in children oftentimes. What happens is this then causes a patient to develop what? A peritonsillar abscess. The peritonsillar abscess then progresses and breaks through the superior pharyngeal constrictor into the parapharyngeal space. And they get what's called a parapharyngeal abscess. So what patient population would I want you guys to remember for this one? Think about this one. This one particularly, I want you to think about this one in children. So this one, I want you to think about in children or pediatric patients. All right? So think about the spread from a peritonsillar abscess in children. All right? The other cause in adults is usually a dental abscess. So they have an abscess of one of their molars. Which molars? Usually it's like the 3rd molar, the lower thirds. So usually this is a dental abscess of the lower 3rd molar and it gains access to that space. So either this thing is, it gained access in one of 2 ways. Let's actually make sense of it here. One is you had a tonsillopharyngitis, broke through the tonsillar capsule, got into the peritonsillar space. From here, it then broke through the superior pharyngeal constrictor muscle. And when it broke through that superior pharyngeal constrictor muscle, it started to spread and spread and spread into this space. All right, that's one mechanism. You guys got that? Is that it started here, here was 1, here was 2, and here is 3. All right, started off with the tonsillopharyngitis, to the peritonsillar abscess, to the parapharyngeal abscess. The other one is that you had an infection here at the root. All right, so you have a dental infection, an abscess here. And from that molar, it breaks through and it travels backwards into this space. And now you have an abscess that's filling this space here. All right? Do you guys get the point here? So that's 2 ways that it really can happen. There is technically one more way, but it's rare. And that's what else is really close here? The parotid. So if someone had a parotid infection, right? So sialoadenitis of the parotid glands, that could also potentially spread into this space as well. But I want you to remember two of them. One is a contiguous spread from a group A strep that caused peritonsillar and a parapharyngeal, or a dental abscess. For dental abscesses, I want you to associate this more with the adult cases. All right. So that would be the way that the patient would come in. They'd say, oh man, I had a dental abscess, I've been having some tooth pain. All of a sudden now they have some other features, and we're going to talk about what those are. Or hey, it was a kid who had strep throat, all of a sudden got a peritonsillar, spread to the parapharyngeal space. Well, now we got to talk about what happens here. Well, it's the same kind of dang thing here. We get two components here. We're going to get a mass effect, and we're going to get some irritation. All right? So we're going to have a mass effect. The mass effect is actually pretty straightforward, except sometimes it's hard to tell because look at how this all can happen. You're going to be taking this, and I don't want to mess up the diagram hardcore here, but imagine all of this is under pressure. It's going to push this whole wall this way. And so if I push this whole lateral side of the pharyngeal wall in medially, you'll have bulging there, which sometimes is hard to tell if it's the tonsils. Sometimes it might even push the uvula. So the one thing I want you to think about here is that all that abscess that's building behind that is going to cause the lateral wall to bulge medially. So the lateral pharyngeal wall is going to bulge medially. So that's one thing, all right? The second thing is, whenever you get an infection of this parapharyngeal space, the posterior parapharyngeal is going to have more of that mass effect. And if you kind of start tracking over here into the anterior pharyngeal space, it's going to be near the jaw, the mandible. And so what I want you to think about here is, let's say here I have like parts of the mandible here, right? All right. This infection, generally, when you look at this part of the mandible, it tends to occur right here around the angle. So that abscess, it's occurring behind, it's behind the mandible. So here would be, if you had to think about it here, there would be a muscle that you would have here. Here is which one is this one? The masseter. And then behind this one, which you can't really see, but if I were to have it there, which one would this one be? That would be the medial pterygoid, right? So this is behind, it's behind that area there. And so it's going to cause kind of a bulging kind of a component there right on the angle of the mandible. And so because of that, if I get that infection that builds up in this space, it's going to tent the skin in that area of the mandible. And so what will I get? I'll get some neck swelling, but it'll be right around the angle of the mandible. So you'll get some neck swelling near what? Near angle of the mandible or the jaw. And that's really going to be in which space? So technically the lateral pharyngeal wall, when that bulges, that's going to be from the posterior space. That's going to be more posterior space. For the neck swelling near this point of the angle of the mandible, that's going to be more the anterior space. But again, you can have this in both of them. The next component here is the irritation. So you're going to get irritation of two things. You can get irritation of what muscle is in this area. Think about it, dude. Come on. Think about it. Or even here. You're going to get all of this occurring right here. It's going to start bulging at that angle of the mandible. What muscles right here? I told you that before. The medial pterygoid. And if the infection is spreading around the carotid sheath and it gets into the carotid sheath, what can you get irritation of? The carotid sheath. Oh my gosh. So there's irritation of two things. One is the medial pterygoid. What happens if you have involvement of the medial pterygoid? You're going to get trismus, which is inability to kind of open up the mouth, right? The other thing that we're not going to talk about yet because it's a complication and it doesn't always have to happen is I'm going to talk about the carotid sheath invasion. So if it gets into this area, it can cause irritation of the carotid sheath. We'll get into some scary, scary complications of that one, especially something called Lemire syndrome. And you can get carotid blowouts and you can get cranial nerve palsies. They're relatively rare, But the one thing I want you to think about with these ones is if a patient came in with a sore throat, a fever, a muffled voice, and they had some drooling, you look in their mouth and I say, tonsils pushed out, uvulas deviated to the contralateral side. You would then say peritonsillar. If I said, hey, the patient came in, sore throat, muffled voice, and they had some drooling, a fever, you look in the mouth and you notice that the lateral pharyngeal wall, maybe the tonsil and the uvula bulged, but then you look around the jaw line, that angle, and you notice some swelling there. Could be parapharyngeal. They both can have trismus. Which one's worse? Usually parapharyngeal is going to have much more severe trismus. The other thing that you can see here is it can get into some of these muscles around the neck and they can get some torticollis, but I don't want to go that far. All right, I want to save that because there is some muscles that are really, really critical for understanding the next complication and the next disease. All right, so we got the differences here. Both of them can be due to group A strep and then like this could be a spread from the tonsil to the peritonsillar space. This one could be spread to the peritonsillar space and parapharyngeal space. Another one that I really want you to think about in adults is if it comes from a dental infection, an abscess that spread from the third molar. So the feared retropharyngeal abscess is pretty terrifying as well. Now you're getting kind of a trend that things can spread via these spaces, right? So when I talk about etiologies, really what happens with this one, it's a tiny bit different, right? So there's usually two particular etiologies, and the reason why we break these up is because it is important. In children, so we'll preface this first, the way I should have done it first with the parapharyngeals. In children, they use a lymphatic pathway by which we see this retropharyngeal abscess. And the reason why I say children is this oftentimes is in children less than 5 to 6 years of age, all right? The reason why I tell you this is because when we talk about these, usually these lymph nodes that sit within the retropharyngeal space are technically called the nodes of Rouvier. Typically they atrophy and they kind of go away as you start to get greater than 6 years of age. So we see that these types of retropharyngeal abscesses definitely have a predilection towards children who are on the younger side if it causes what will lead to, we'll talk about it, it's called suppurative lymphadenitis. So here's what I want you to understand. Let's say you have a child, they're really young, and they get a upper respiratory tract infection, right? So they get an upper respiratory tract infection. And this is usually, it's most often mixed. It's probably a mixture of viral and bacterial. And this could be of the sinuses, it could be of the middle ear, but it's oftentimes, guess what? Most often associated with like a tonsillopharyngitis. So it's usually like some type of tonsillopharyngitis. What happens is the infection, let's say it starts here. You get an infection, gets into these tonsils, right? What will happen is you have lymphatic channels. And the lymphatic channels, they connect to these lymph nodes. Here I'm gonna have some lymph nodes. I'll have a couple lymph nodes here. And what happens is this infection, it'll spread. It uses lymphatic channels that it can then move to these lymph nodes. And when it moves to these lymph nodes, the infection gets into those lymph nodes. And basically what starts to happen is it causes a lot of inflammation, enlargement of these lymph nodes. And eventually they build up so much pus in them that I'm not even kidding, they just pop. And when they pop, they spill out all this kind of like infected material into this space. So you know what they call this? They call this suppurative lymphadenitis. So here's what happens, again, to kind of prepare you for this. First thing, I'll do it over here on the side. First thing is you have an infection. You start off with a upper respiratory tract infection. Usually it's a mixture, it's probably viral and bacterial. What do? The second component is they spread to lymph nodes. What are these nodes called? They're called the nodes. Oh, here we go. I think this is how you spell it, but it's called the nodes of Rouvier, right? They love to say these things. So it spreads to the nodes of Rouvier. So the infection gets into the tonsils, accesses the lymphatics, and gets to the nodes of Rouvier. Where are the nodes of Rouvier? That is important to remember. What space did I tell you this is? The retropharyngeal space. So where is it found? The nodes of Rouvier in the retropharyngeal space. Once it gets into this and it starts causing infection and it starts actually causing pus to accumulate in the lymph nodes, what is that called? We call that suppurative lymphadenitis. And then again, this is of what lymph nodes? The nodes of Rouvier. I love to say that word. I didn't want to spell it. Now, once that happens, these start to break open. So not only do you have this suppurative lymphadenitis, which is pus kind of building up, they start to break open. And then you have the, let's just say, the breakdown of the lymph nodes. And it goes into what space? That retropharyngeal space. So now, once they bust open, they have all of this kind of pus material that's sitting here in this space. Tell me that's not absolutely horrific. That's one mechanism, and that's the one that they are going to probably test you on for the exam. For the adults, it's a little bit different. So this is the children. The children, think of the children and the upper respiratory tract infections. For the adults, it's a little bit different. For the adult, it's the person who's eating a chicken, right? They're eating fish. They're doing something like that that has bony structures. They're sucking on that chicken wing like hardcore, and then all of a sudden, I don't know why, but they would swallow it. And when that happens, there is some type of trauma. So we often say that in these cases, it's usually in adults, it's some type of trauma. So it's trauma. And that could be like so many different things, right? I was just being funny, but a chicken bone could obviously be something. But usually bones, like fish bones, intubation, so you're being a little aggressive with the intubation. You're doing scopes, so maybe some type of endoscopy. Again, you get the point. It's some type of instrumentation or something rough that's causing trauma. Well, why is that an issue? Here in the posterior part, I told you, this is the posterior pharyngeal wall. So here, let's write that down. This is the posterior pharyngeal wall, which is what part here? Right here. Then you have the superior pharyngeal constrictor. Then what is this other black line right here? I'm going to put it like, if I can find a dang place to put it, I'm going to have to kind of dissect here. But to remind you, this is called your bucco. Hey, bucco. So buccopharyngeal fascia. I think Austin Powers. Fascia. Then you have the pink one there. This pink one here is called the alar fascia. So we have the buccopharyngeal fascia, and then we have the alar fascia. The space which is sitting between those is called the retropharyngeal space. If I have injury where I have trauma and I break a hole through this area here, look what I broke. I done broke it at it. I broke this buccopharyngeal fascia, the posterior pharyngeal wall. I create an opportunity for what? Pathogens to get their way in here. And if they can sit in here, they can create a collection of pus. When that starts to happen, this space comes under pressure and it has mass effect. And it bulges the posterior wall forward. Oh man, so you get the point here that with this, we're going to have, again, mass effect. So what's the mass effect going to do? Well, the mass effect is going to have two components here. One is you're going to bulge the posterior pharyngeal wall forward. That's really it. So you're going to bulge the posterior pharyngeal wall anteriorly. And that's pretty terrifying, right? But there's one other thing. There's an irritation component. I got to go to this next part here. I know it's getting a little messy, but again, here's the retropharyngeal space. What was this space again? I wrote it in here. What was it called? This is called the danger space. And then what was this last fascia here in blue? I'll write it over here. This last fascia. This last fascia in blue here was called the prevertebral fascia. And then right here is these muscles called the prevertebral muscles. Whew, man, the arm is killing here today. This is going to be things like the longus coli, which are deep neck flexors. So here's what I want you to think about. If you have an infection in this this space. And it's pretty easy for it to unfortunately travel or cause irritation. It can travel into these areas. It can cause direct irritation. Those prevertebral muscles, if they get irritated, dude, we're gonna have some problems. So we're gonna get irritation of the prevertebral muscles. And the problem with this is if you get irritation of the prevertebral muscles, they're supposed to want to cause you to flex, right? If you cause irritation of these muscles, just like the medial pterygoid, it's gonna get inflamed. When they get inflamed, what do muscles do? They spasm. And when they start to spasm, what is their function? To flex. And so what they'll do is they'll cause spasm of those muscles. And that's gonna push you into more of like a flexion of the neck. So you're gonna have spasm of the muscles, which causes them to be like two things. One is it causes a slight flexion of the neck because they might be in a constant state of kind of contraction because they're spasming, right? The other thing is, if you have muscles, you ever had like a muscle spasm and you want to try to do the thing to oppose it? Like if you have a spasm in your back, you're like, oh, if I move a specific way. We don't want to go against that kind of action. And so sometimes these patients, not only will they have a slight flexion of their neck, but they refuse extension of the neck. And on top of that, if you cause spasm of muscles, it can cause the muscle to contract and contort your neck in a very weird way. So what's another thing that they could get? Torticollis. So there's a couple different things with the spasm of the muscles. They get slight neck flexion. They get refusal to extend the neck if you try to do it. And then also it may cause some degree of torticollis, which is kind of like a weird kind of formation, like the weird kind of twisting of the neck. That's usually the things that we get concerned about with this patient. So with a retropharyngeal abscess, the scary components here is that if it gets access to the danger space, oh boy. Parapharyngeal, if it gets into that carotid sheath, oh boy. We'll talk about Ludwig's angina in a second. Peritonsillar, at least we can be thankful that it's not one of those where it can spread, but it directly isn't going to cause any kind of dangerous kind of complications. I think we got this one down. We now know how to really differentiate this one when we look in the mouth. You're not seeing any neck swelling. You're having a very specific type of swelling inside of the oral cavity. We have a very specific clinical picture, and we have some very specific changes in their neck musculature and movements and willingness. Ludwig's angina. Ludwig's angina is terrifying because time is of the essence. Time is of the essence here. What's usually the etiology with this one? It's usually, for the most part, going to be an infection of the molars, all right? And so usually this is going to be some type of dental infection, usually like a periapical abscess. And usually it is of the third or even the second lower molars, right? So the mandibular ones. Now, what happens with this is, with these, you have an infection here, like near this root. And what happens is this infection, it's kind of weird. Usually, here's the mylohyoid muscle again, right? It usually empties, usually the root is at least below the mylohyoid muscle. And so it gets into this space, starts to cause again an infection, so cellulitis, and it's rapid and it causes necrotizing, so it basically kills a lot of the tissue. Then what it does is it comes backwards and posteriorly, it wraps around the mylohyoid. So it's going to wrap around and then it's going to fill up this space, the sublingual space. And again, it's going to cause cellulitis here. So what we see here is we have a patient who comes in, they have a dental infection, usually that third or that second lower molar, and again, it's usually an abscess. It breaks into this space here, that submaxillary space, wraps around into the sublingual space, and this entire submandibular space gets filled. I told you before, there's limitations to where this thing can move now. So as this infection gets worse, it's going to push on the floor of the tongue. And it's also going to push against that cervical fascia, which is limiting it. Here, I'll draw the cervical fascia in orange. So here's that cervical fascia. Maybe we kind of have it right here. It's moving down. It's limited from moving that way. So it's limited, it has its limitations here if you want to think about it. And so because of that, whenever it expands, it's going to push against the tongue and push the tongue which way? Well, it's going to push the tongue, you would say, upwards, but also posteriorly. So you're going to push it like this. Boop, 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 boop. And so what's going to happen is that this patient is going to have mass effect, but there's going to be two components of the mass effect. One is the mass effect is going to cause, you're going to see obvious swelling at the base of the tongue, right? There's going to be, I mean, I'm not kidding. You're going to look at the mouth and you're going to see, if you had them lift up their tongue, there's going to be massive swelling on the floor of the mouth, right? So that's one thing. You're going to have massive swelling. But that massive swelling, all right, so you'll have swelling on the floor of the mouth. Sometimes you may even see pus there. So swelling on floor of mouth. But the concerning feature is that it can push the tongue posteriorly and superiorly. So it pushes the tongue, because again, it's limited. It has nowhere else to go. Its superior border is the tongue, the floor of the tongue. And it's going to push the tongue backwards and superiorly. Superiorly and posteriorly. So it pushes the tongue superiorly and posteriorly, protruding or obstructing the airway. I mean, tell me that's not absolutely terrifying, because if that happens and you don't actually get to it enough, you can completely block this thing off and cause asphyxiation. So that's why this one is super, super terrifying. The other component of the mass effect, though, is that it's limited anteriorly in this submaxillary space by the cervical fascia. And so because of that, it's going to kind of push against the actual cervical fascia in the neck, and it's going to tint out the skin and the swelling of the neck. They have bilateral swelling of the neck. Basically, they have a bull neck. I'm not kidding. That's the way I would describe it. Is they have a bull neck, but the textbooks like to describe it a little bit differently. So technically, we use a very specific, we call it a bilateral woody induration of the neck. All I want you to know is they got a big old swollen neck. So we can say a bull neck or a bilateral woody induration of the neck. If I look at a patient, they're coming in and they'll be in obvious distress sometimes. Sometimes maybe not. But if they come in and say, I got pain somewhere in the mouth, they have a fever, they have lots of drooling, they have maybe some changes in their voice. You look in their mouth and you see that the floor of the mouth is swollen. You see that the tongue is pushed upwards and posteriorly. And you try to look at their neck and their neck is significantly swollen. That's going to scream Ludwig's, and you're going to want to call somebody immediately, because this thing, if you don't get control of it, look what can happen, dude. I won't be able to get any air in this way. And if I want to get air in this way, it's going to be limited. And so that's why this one carries the highest risk of airway obstruction. And that's pretty critical to understand. Now, the last thing I will say is all of these infections that we talked about, usually they are polymicrobial. What the heck does that mean? It means it's not just one microbe. It could be group A strep, but it could also be other things. So a lot of the infections that I want you guys to remember here is usually Streptococcus viridans. It could be Streptococcus pyogenes and anaerobes. So again, I want you to remember that this is polymicrobial, meaning that you could have infections of Streptococcus, Staphylococcus, and anaerobes. And the reason why that is important is because when you treat these patients empirically for these infections, you have to be able to cover strep. You have to be able to cover things potentially like Streptococcus viridans, Streptococcus pyogenes, and anaerobes. And that's what I want you guys to take away from this. But before we actually end off and get into the diagnostics, we got to talk about what does it look like in these three whenever a patient has airway obstruction, when they have mediastinitis, and when they have carotid sheath invasion. All right, so when we talk about complications of deep neck infections, again, I did tell you guys, we went over the spaces, we talked about their anatomy for relevant reasons. We went over the potential etiologies, the triggers as to why these abscesses and necrotizing cellulitis would even form. And we talked about overall kind of the effect of the mass effect and irritation of nearby prevalent structures. But one of the critical things to know about these is their capacity to cause true mortality producing kind of like complications. And so airway obstruction is obviously going to be the immediate concern. Think about this for a second. If you have a patient who has a significantly large retropharyngeal abscess, and oftentimes we define that like largeness as greater than, I know it's so ambiguous, but greater than 2.5 centimeters. You're like, oh, that's big? Wow, I'm doing all right. No, I'm just kidding. But you get the point. Greater than 2.5 centimeter, pretty large abscess. It's causing mass effect. And that mass effect is, think about this, as air is flowing through here, you have an obstruction here. And as air is flowing through here, you have an obstruction here, because the whole point is for air to flow down where? Into the larynx, into the airways to perform gas exchange and undergo the ventilation process. So if I have that abscess there, it is obstructing the airway. And as a result, you're going to end up with some pretty terrible complications. So again, in this example, I want you to understand that retropharyngeal abscesses, basically what do? They obstruct the airway, especially in the level of the pharynx. Now, because of this, what would this kind of patient look like? What would be their overall presentation? Well, airway obstruction usually presents with things like stridor. They may present with hypoxemia. They may present with cyanosis, right? There could be a lot of different ways that they present, but oftentimes more than not is they may have some type of decrease in their SpO2, which is their saturation of oxygen. If you got an ABG, that might be low. And so this is kind of relevant, particularly for hypoxemia. If the oxygen delivery to the tissues is persistently low in scenarios of hypoxemia, they can develop a bluish discoloration called cyanosis. If you have an obstruction of the airway as you're trying to bring air in, this may produce potentially a stridor. And then on top of that, the other really concerning feature of this is when these patients have this kind of problem where they're really struggling to bring air in, they may work a little bit harder. And so there may be an evident increase in their work of breathing. Maybe there's nasal flaring, maybe there's intercostal retractions, maybe there's use of accessory muscles. You get the point. That would be a concerning feature, all right? In combination with things like drooling, with trismus, with muffling of their voice, with a sore throat, with fever, that's when you're concerned about this, right? So that's what I want you to take away from this one. With Ludwig's angina, it's the same concept here. We have some type of necrotizing cellulitis that's filling up the sublingual space, that's filling up the submaxillary space. This collectively is called the submandibular space. It's limiting its ability to be able to spread somewhere because of the anterior cervical fascia and the base of the tongue. So what does it do? It pushes the tongue posteriorly and superiorly. You create a bull neck which compresses on the neck structures. Either way, as air is kind of coming in here or it's coming in this way, you're leading to an obstruction in that pathway. You guys get the point. As a result, you don't get enough air down into the lungs to undergo its gas exchange process. So again, another one here is besides RPA, that carries a pretty high obstructive risk. The other really, really scary one is Ludwig. So Ludwig angina also carries a really high risk of airway obstruction, probably more so than a patient who has a retropharyngeal abscess. So you guys get the point. This is the ones that whenever we see these, what should you prioritize? You should prioritize airway management. Maybe I need to intubate the patient and do it quickly. And sometimes with intubation, I might not be able to do my traditional rapid sequence intubation. Maybe I have to do things like I have to do nasotracheal. Maybe I have to do some type of fiber optic process. So it becomes challenging, and that's why airway becomes the king in these kinds of scenarios. Okay, let's now talk about, let's actually just go through this one and then we'll pop over here to the right. Let's talk about descending necrotizing mediastinitis. That's a heck of a name, right? It goes back to a retropharyngeal abscess, right? I told you that this was the retropharyngeal abscess. So we're going to go through this step by step. So retropharyngeal abscess is really the trigger here. So that's going to be your starting point. A patient will have a retropharyngeal abscess. So once you have that retropharyngeal abscess, where would it be? Let's go back. Let's say this black line is the buccopharyngeal fascia. This pink line, here, we'll do this again. We'll put here, this is the prevertebral fascia. I won't write all this out. I'll just do the fascia part. I'll just put alar. And here is your bucco, I don't know why, that just makes me laugh. pharyngeal fascia. And so the spaces are kind of representative here. This space here between the buccopharyngeal and the alar fascia is the retropharyngeal space. And so here is where the abscess starts to form. All right, so here's the abscess. The problem with this abscess is that eventually it kind of terminates at the level of T4. And so you're like, okay, well, how the heck would that get into the mediastinum? That's not really the issue then. What happens is there's a space between the alar fascia and the prevertebral fascia called the danger space. If this spreads through that fascia, it can then get into the danger space. When it gets into the danger space is problematic because it can actually go all the way from the base of the skull down to the diaphragm. Now, gravity, right, will pull this pus down into the actual posterior portion or close to the mediastinum, and also changes in intrathoracic pressure. So two things. So again, here, let's actually phrase it like this. What pulls the pus downward to even get it near the posterior mediastinum? There's two things. One of those things is gravity. Right? Gravity. And with that gravity, that's going to pull the pus downwards. Right? The second thing is intrathoracic pressure changes. So intrathoracic pressure, and we're going to represent changes by the delta sign. When you have your inspiration, you drop the intrathoracic pressure. That's going to suck things into the, like suck air into your lungs. Those things pull the pus downwards into this area, which is very, very, very close to the mediastinum. And obviously the mediastinum is broken up into the different compartments. You have the superior mediastinum, you have the anterior mediastinum, the middle mediastinum, and the posterior, right? So here I'll put superior, anterior, middle, posterior. So here's the superior mediastinum, right? And this is all inferior, which is broken up into anterior, middle, and posterior. Once this infection is moving into the danger space, right? So what pulls it downwards? Gravity and intrathoracic pressure pulls it down the danger space. So again, we're going to have infection starts at retropharyngeal space. Second thing is it moves into the danger space, travels inferiorly, and moves into technically it starts with the posterior mediastinum. And that's how this all happens. So again, first thing is you have an abscess that starts in the retropharyngeal space, moves into the danger space through the alar fascia, travels inferiorly. How? By gravity and intrathoracic pressure changes. And then from here, once it gets down to where it needs to, guess what it does? It invades into the mediastinum. Which one particularly? The posterior. But again, once this infection is in this area, it's a big cavity, which guess what it can do? It can start moving into all the different parts of the mediastinum. So it doesn't just have to be the posterior. It could be any part of the mediastinum. Then once you get this, my dudes, my dudettes, you're gonna get inflammation of the mediastinum. And that's where we see some problems. So then the fifth component here is that you have inflammation of the mediastinum. So inflammation, once that pathogens get in there, that pus gets in there, inflammation of the mediastinum. Now the question that I'm going to ask you is, okay, what would this look like? Here is going to be the mediastinum. I'm going to kind of outline it in orange. Here's like the superior mediastinum, and then we're going to get all down here into the inferior. All of this is going to be walled off here. And what I'll do is I'll do it like that. Everything inside of that orange is the mediastinum. When you cause inflammation, which we're going to represent in here, we're going to kind of just show this is the inflammation of the mediastinum. You got to think about all the dang things that are in the mediastinum, bruh. What's some really important things? The esophagus, the aorta, the trachea, the heart. There's all of these things. The most common problems that we get worried about with this is that these pathogens, they actually, when they're in this area, I'm not even sure, they fart. You're like, what? What did he say? they fart, they produce gas. They actually can cause gas production. And so one of the things that happens here is that these pathogens, these anaerobes, they like to produce a lot of gas. And that gas can fill up in this cavity. So now imagine I have some, like, let's say I just have gas, I have some air, right? And this is that air, really, who is producing it? It's the pathogens, these anaerobes. These pathogens in here are causing some air to actually accumulate. This is that gas from the anaerobes. That air is going to start kind of filling this space and kind of distending it. And so you get a couple different things. A couple different things present in a patient who has mediastinitis. Let's actually write this out. So here's a patient who has mediastinitis. We see evidence here. All right, mediastinitis. Mediastinitis, I missed the I. It's always good to double check there. So here we have the mediastinitis. What is going to happen? Well, the first thing, and this one is pretty obvious. Where is your mediastinum with respect to, like, if you had pain somewhere, where would it be? The chest. Usually this pain is like pretty deep though. So we kind of like to say that this is a retrosternal chest pain. All right, and it's also sometimes defined as like more pleuritic, so it changes with breathing. So that is something to think about here. And it's also kind of makes sense because if you have inflammation of the mediastinum, guess what's really, really close to it? The pleura, right? So it's going to have more of that changing with inspiration. The other component here is that because of the air production, that air can get in, it can kind of fill the mediastinum, and it can kind of, as it fills the mediastinum, what it'll do is it'll kind of make the mediastinum appear more wide. So it kind of opens, it pushes out, right? Pushes out, so the air kind of pushes up. And so what happens is if I were to do two things, if I were to do a chest x-ray, which you're probably like, oh wait, why are we talking about that? If I were to do something called a chest x-ray, there'd be two things that I would potentially be able to see. One is because of that air, there would be a widened mediastinum, right? So the mediastinum would be wider. Let's actually write that down. There may be a widened mediastinum on the chest x-ray. And the other thing is that that air, what happens is it can actually be visible. So you have a widened mediastinum, but the air, sometimes you can see it. And so we call it a pneumomediastinum. So you have a widened mediastinum, but you actually have what's called a pneumo. So the reason for that wide mediastinum is a pneumomediastinum. And this would actually be sometimes visible on the chest x-ray. Sometimes you actually have to do a little bit more, and you have to do like a CT scan. But that is something else to consider. So on the chest x-ray, you may either see a widened mediastinum to consider this, or you may see a pneumomediastinum. Sometimes this air finds its way, and it can actually, you can get some air, and I'll represent here. Let's say it finds its way, and it kind of gets here, moves upwards into the chest. Maybe it moves upwards here into the neck area, and you get air pockets that form in the chest, some air pockets that form within the neck. And they call this subcutaneous emphysema. So another thing that you may see on the chest x-ray is you may see subcutaneous, so we'll put subcutaneous emphysema. I hate spelling. Emphysema. Now, with the subcutaneous emphysema, there is a potential physiological, or there is a potential physical exam finding. If I go and I press on their neck or on their chest, what would I have? What would I feel? I'd feel some crunching. And that crunching from this sub-Q air, so this sub-Q air can precipitate upon palpation a potential sign called crepitus. And that crepitus, we technically give it a particular name. We call it Hammond's sign. And that's basically, it's just crepitus upon palpating the chest and the neck. So that sub-Q air that leaked out, if I go and I palpate it, and I have the presence of crepitus, we can call that a Hammond sign. So if they have retrosternal chest pain, their chest x-ray shows some weird potential things, bro. They got Hammond sign. I'm starting to think that they could have mediastinitis. Here's the other problem. In the mediastinum, do you know what kind of things you have in there? Bunch of vascular structures. Things like the aorta, things like the vena cava, things like the, you got bunches of them. This pathogens can access your bloodstream. So let's actually pretend here that I have just a blood vessel right here. This pathogens, dude, right away, they can easily access your vascular system. When they access your vascular system, they can cause a bunch of problems like sepsis. And so here, that's one of the biggest concerns, is that the pathogens actually get into the bloodstream and the patient gets something like sepsis. So that's a potential fear. And so one of the big scary things here is you can have a patient who has a sepsis-like picture. They look sick as crap, dude. I'm not kidding. And so the sepsis is the weird kind of picture where they may have things, for example, they may have a very high white blood cell count, they may have a fever, and they may even have their blood pressure can be really low and their heart rate can be really high. And so these are all pictures that a patient is really as sick as can possibly be. So having the presence of a very high white blood cell count and a fever, low blood pressure, and some tachycardia, in combination with retrosternal chest pain, some chest x-ray findings, some physical exam findings, I'd be pretty concerned, especially if I looked in their throat and I noticed that they had an abscess in the back of it. Do you see why this is so dangerous? This has the potential to cause mortality-producing effects. That's why we really need to know this one. All right? All right. I think we got that one pretty good. So let's finish off here with the next one, which is the parapharyngeal. So again, Ludwig's, definitely the highest risk of airway obstruction. Retropharyngeal definitely can do that as well. Retropharyngeal, I want you to associate with descending necrotizing mediastinitis. How? It gets into the danger space. The danger space goes all the way down to the diaphragm, gets into the mediastinum, inflames the mediastinum. When it inflames it, you get pain in that area, retrosternal chest pain. You get inflammation, you can get fever. On top of that, it can cause a lot of chest x-ray findings and physical exam findings. But the scariest thing is it can cause sepsis and the patient can die. And that's what we have to be able to identify. With parapharyngeal, this one's, I mean, I'm not kidding. It's also pretty stinking terrifying. Do you guys remember? Right here, there was this imaginary line that broke up this parapharyngeal space into the posterior and anterior, right, at the styloid process. When a patient has an infection, or they have this abscess, that's sitting back here in this posterior parapharyngeal space, here's your carotid sheath. What if this infection invades in, seeds through it, starts damaging the carotid artery, starts seeding in and getting into the veins, starts getting in here and really agitating some of the cranial nerves? That's when we start to see problems. So again, the key thing I want you guys to understand here is that this is a patient who has a posterior parapharyngeal abscess. And then what happens? It invades the carotid sheath. And in the carotid sheath is a bunch of different structures, right? So you have a posterior parapharyngeal abscess. And what happens here is, this is the first thing, you have a posterior parapharyngeal abscess. It invades the carotid sheath. And then you get vascular and neurological complications. So you can get vascular and neurological complications. Now, I'm going to preface something. I told you before that most often in any of these deep neck infections, what are they? Polymicrobial. Streptococcus pyogenes, Streptococcus viridans, and anaerobes. When we talk about invading the carotid sheath, we do, especially when it comes to this next one that we're going to talk about, with the internal jugular vein thrombosis, because when they do in here, they cause all these vascular and neurological complications, possibly. Usually, the pathogen that I want you to see this most often with, so there is a really important thing here. So let's say here I have, again, here's my abscess, and it's in this area, it's filling up this space. What I really want you to know is the ones that really cause, particularly, especially the vascular complications, there is a specific pathogen that we see the most risk of this happening in. So I want you to remember this. The highest risk pathogen is going to be which one? I want you to remember, it's a weird heck of a name, but it is called Fusobacterium necrophorum. Sounds terrible, honestly, just by the name of it. Sounds like some kind of Harry Potter spell. Fusobacterium necrophorum. So Fusobacterium necrophorum. Now, with these, what I really want you guys to understand is that whenever you get this is a particular type of anaerobe. It's a nasty anaerobe. If it causes this kind of infection, one of the scariest things that we see associated with this is the internal jugular vein thrombosis. But I don't want you to always associate with this because jugular vein thrombosis can happen from anything. But when it happens due to a septic thrombi, in other words, that pathogen gets into the space. We're going to zoom in here now. It gets in here into the internal jugular vein. But when it does it, it forms thrombi, but it forms septic thrombi, which means that you have clotting material that's all mixed in with clots. So you have clots and you have pathogens all up in that thing. So this is, what do we call this? This is called a septic thrombophlebitis, which means that you have inflammation of the blood vessel. So that means that the lining, so I would represent it like this. I have inflammation of the blood vessel wall, right? Inflammation of the blood vessel wall, which is the actual phlebitis. And then on top of that, I have a thrombus. But what kind of thrombus? It is a septic thrombus that is inside of there. This is most often associated with the Fusobacterium. But when it is, we like to be particular. We got to give it the name to something because someone probably figured it out. You know? Hey, credit to them. But it's called Lemire syndrome. Lemire syndrome. Now, Lemire syndrome is primarily, whenever we talk about parapharyngeal abscesses, they're usually due to Fusobacterium necrophorum, and they are primarily the most common kind of issue that you can have when you invade that carotid sheath is this one, the internal jugular vein septic thrombophlebitis. When this happens, what will we see? Well, internal jugular vein runs where? It runs in the neck. So if it's inflamed, what's going to happen if it's inflamed there? It's going to be painful. So one of the things that's going to happen is because of this septic thrombophlebitis that's going to be appearing all right here, this will precipitate a kind of tender neck pain. So it'll be tender upon palpation. So let's actually write that down. Let's actually do it in, let's just say in red. You're going to have a tender neck pain, especially along, it runs along the sternocleidomastoid. So along the sternocleidomastoid. That's where you're going to have this. So if a patient, you're palpating and you feel kind of maybe like some nodules, it feels hard, and it's really, really tender, maybe it's red, that could be due to the septic thrombophlebitis of what vessel? Of the internal jugular vein. So septic thrombophlebitis of internal jugular vein, but that's not it. So they got some tender neck pain, right? Especially upon palpation. Here's the scary thing. What if that clot breaks off? So now I have a septic thrombi that then breaks off. So it was a thrombus, but now it becomes a, what is this called? An embolus. And when that embolus forms, where can it flow? It can go down the superior vena cava into the right atrium, from the right atrium into the right ventricle, from the right ventricle into the pulmonary trunk, from the pulmonary trunk it can go into the pulmonary arteries, and then once it gets here, it can go and deposit these septic emboli. Where? In the lungs. And oftentimes they're kind of like in multiple different places and they look like cannonballs. You're getting a kind of a terminology that I'm going to give you here. They call these cannonball lesions. And so they may also have, the patient may have some associated problems with this. So maybe they have things like dyspnea. Maybe they have things like hypoxemia as a result of this. Right? You can have any of these things potentially as a process of the result of these lesions, these septic emboli that get stuck in the lungs, right? They definitely can cause potentially presentations like this. Oftentimes, what you may end up doing is you may end up getting some imaging. And when you get something like a chest x-ray or a CT scan, probably more likely the CT scan, you'll look at these and they give them very particular names. And these are called cannonball lesions. I already kind of told you that. So cannonball lesions that are going to be apparent on a chest x-ray, but more specifically probably the CT scan. So you're going to get these, and kind of when you think about it, what these really, why they really can cause dyspnea and hypoxemia is because they're kind of like septic emboli. They're kind of like a septic PE. So you theoretically, they can get into the lung parenchyma, but they can also block off a pulmonary artery. And if I block off a pulmonary artery, I could have patients who present with PE-like symptoms. That's why whenever I say dyspnea, hypoxemia, tachypnea, so we can even add that in, dyspnea, hypoxemia, tachypnea, they can have more of like what we call a septic PE presentation, or we can just say a pulmonary emboli presentation. So PE type of presentation. That's not physical education. That's pulmonary emboli-like presentation. So that's what I would want you guys to think about. If you see someone who comes in, they had that abscess, the parapharyngeal, all of a sudden they're presenting with some signs of respiratory distress. They got some tenderness along their neck, along the SCM. You get some imaging and you find these cannonball lesions all over the place. You should think about Lemire syndrome. And what's the pathogen you should associate it with? Fusobacterium necroforum. Woo-wee. Okay, what's the other thing? Cranial nerves. There's a bunch of cranial nerves in here. What I want you to remember is, again, we talked about the vascular component, particularly the IJ. We'll get into the carotid last. But this infection gets into this carotid sheath. Maybe it involves the internal jugular vein and starts actually causing maybe some compression, some inflammation, some damage of the cranial nerves. Well, what cranial nerves? You have here 9 and 10. That's glossopharyngeal and vagus. What would these potentially cause? Well, you could have things like maybe dysphagia. That's definitely potentially problematic, right? Because we know that the vagus obviously controls the esophageal contractions and ability to move things down during deglutition. We also know that the vagus controls a lot of our speech. So it obviously controls a lot of the muscles that are involved within the movement of the vocal cords. And so dysphonia is also a possibility. So dysphagia, dysphonia. And then obviously these both are involved in your gag reflex. So they may have a diminished or reduced gag / maybe even cough reflex. But that's kind of what I want you to potentially remember, is there could either be some type of decreased cough reflex and gag reflex, or it could also just be that they lose it. So that's definitely problematic if we have things like that happening. Cranial nerve 11, this is going to be the accessory nerve. So they may have some trapezius weakness, right? So they may have some trapezius weakness. So maybe there can be some sagging of the affected side. So maybe if they had some type of trapezius weakness, there may be potentially some sagging or difficulty in being able to elevate the trapezius muscle. Cranial nerve 12, hypoglossal. They may have some type of tongue deviation, right? So they may have some tongue deviation as well. And so these are the things that I want you guys to likely associate with that potentially being the case. But I spent the most part of this discussion on the one that you'll probably likely be tested on more likely, which is the Lemire syndrome. But if you see that these patients do have some type of, again, involvement of these cranial nerves, you can see these potential clinical presentations. Sympathetic plexus is a possibility as well. You got to remember, this thing is also traveling up along with the carotid sheath. If it gets hit, the cranial nerves, especially the sympathetic plexus, it supplies particularly things like the pupil. And so it's supposed to allow for what? Pupillar dilation. If you can't do it, it goes constriction, meiosis. It's also supposed to allow for the sweat glands of the forehead to produce sweat. If you can't do that, you can't sweat. Anhidrosis. And it's also supposed to elevate the upper eyelid. If you can't do that, it droops. So what are the potential presentations? We call that Horner syndrome. We call this Horner syndrome. And again, we can remember Horner syndrome via the particular triad. Let's actually remind ourselves. What is this triad again? Bop, bop, bop. It is, you can't dilate the pupils. So it is meiosis. You constrict them. You can't sweat from the dang forehead, which is anhidrosis. And then on top of that, you have difficulty elevating the upper eyelid. So it starts to droop. You have ptosis. So if you see any of these potential pictures, like a cranial nerve palsy of this potential magnitude, in combination with a patient who you know has a parapharyngeal abscess, you should be concerned that it invaded the carotid sheath. But the first one that you want to think about is the internal jugular vein. Because again, that's the one that we're going to talk about on the attest, etc. Here's the one that's probably the least common, but carries the highest risk of mortality. So I definitely think it's worth mentioning it. Whenever you have an infection in that carotid sheath, what can happen is the pathogens can get near the carotid artery. And it kind of like eats at the carotid artery. I'm not kidding, it like chews away at it. And so it weakens the wall. And if you weaken the wall, you can produce something called an aneurysm. And we call this aneurysm that is due to like maybe this infected materials around it. You know what they call this? They call this a mycotic aneurysm. So one of the things that can happen is that this can precipitate something called a mycotic aneurysm. It can also just kind of eat at the wall too. So there is two different things that could happen. One is it can cause a mycotic aneurysm. And the other thing it could do is it could just literally erode. It could erode at the wall. So it can also cause just small, little, tiny erosion. So a second possibility is it may cause something like a erosion. Either way, the concerning feature here is that you weaken the wall in some way, shape, or form. This thing is under high pressure, bro. If blood is coming through here and you have a small erosion, boom, blood can just shoot out. If blood is coming through here and this is weak enough, blood can do what? Shoot right the heck out. And then the problem with this is you can get something called carotid blowout. I'm not kidding. You're not blowing out your jaws, you're blowing out this thing in the neck. Now that's the problem. So you can get something called carotid blowout. Now the problem with this is that this could be something that is hard to pick out. So what I mean by this is, what could happen is maybe initially you don't really have any kind of symptoms, maybe just a little bit of pain in the neck. But if this gets bad enough, it can potentially block off blood flow. So one potential complication here is a stroke. That's probably one scary dang thing to happen here, is you could end up with potentially a stroke or a cerebrovascular accident. And usually the concept behind this is that you cause inflammation, the infection then causes like a thrombi to form, or you have like some kind of like pseudoaneurysm that forms here. Either way, you end up blocking this vessel off. So that's one thing. And that's definitely scary. But the other one is massive bleeding. And this is probably the one that you would probably never be able to forget if something like this happened. But let's think about this for a second. Here, you have a patient's carotid artery. And what happened is you had the infection, let's say over here, all this infection was eroding. Over here, you had an infection, this abscess, and it caused a mycotic aneurysm, son of a gun. But either way, in both of these scenarios, you create a rupture point. What happens is blood will fill into these spaces, into the parapharyngeal space, and eventually it could even dissect into the actual pharynx. I'm not kidding. You can have patients who have significant swelling that would become acutely worse, or you could have frank bleeding into the oral cavity. And so that's one of the probably the most terrifying complications, but thankfully it is the most rare. But if you have an infection and it eats and erodes away at the carotid artery, you can bleed into the parapharyngeal spaces, and sometimes that can dissect into the pharyngeal cavity. And you can have massive bleeding, hemoptysis, and because of that, this patient could potentially die. So that's what I want you guys to understand, is this can cause just frank bleeding. So technically this would cause like frank bleeding that could potentially present with hemoptysis. So frank bleeding into the actual pharynx and then cause potentially exsanguination if you inhale that, if some of that bleeding, or you aspirate some of that blood, or if it, and then because of that you may have hemoptysis because you're coughing up that blood. So it can potentially cause hemoptysis. It can cause things like, if it's severe enough and it's not treated, it can cause hemodynamic instability. So this is a very, very scary complication. All right. I think we really nailed down deep neck infections, right? We understand the different types. We understand how we define them based upon their anatomical spaces. We know basically what are the etiological triggers that really come from this. We know that all of them are polymicrobial in nature, that they're probably some type of group A strep, there's strep viridans, there's anaerobes involved. We know that they all have similar types of presentations like throat pain and fever and a muffled drooling voice. They may have some type of problem also with just drooling in general. But they have different features that distinguish them when it comes to their oral exam, their neck exam. And then on top of that, we know which ones carry these high risk of scary, scary complications, and we need to identify those immediately when we can. Now that we've done this, let's put it all together and talk about this in a diagnostic approach. All right, my friends, let's dig into the diagnostic approach. So when we talk about deep neck infections, what are the things that we should be thinking about? Well, a lot of these patients, they're going to present with throat pain, right? And it's obviously a result of the infection. It's where it's actually occurring. But that's going to be the most common presenting symptom among peritonsillar abscesses, usually parapharyngeal, retropharyngeal abscesses. And again, even Ludwig angina can actually cause throat pain as well. So that's not the concern because that's a commonality among them. What's a differentiating factor and very, very critical to the decision-making process is assessing if there is any red flag signs or airway compromise. And the reason why I say this is that throat pain doesn't just have to mean that you have a deep neck infection. It could mean something else, like what? Like basically an uncomplicated tonsillopharyngitis. It could be viral, it could be bacterial. So that's the important thing. So remember, first thing to think about is when a patient comes in with throat pain, is it could be strep throat, it could be viral pharyngitis, it could be mono. We talked about that a lot in the throat infection lecture. However, what makes it more concerning is the presence of these red flag signs or any airway compromise. The reason why is if any of those are present, it screams more of a deep neck infection. So let's ask ourselves again, what are these red flag signs? Well, a couple of them would be any evidence of airway obstruction. So this could be stridor, dyspnea. We could even go further than that. They're tachypnic. They have an increased work of breathing. Maybe they're even showing potential signs like they have nasal flaring, intercostal retractions. Anything of that nature is concerning, and that's going to make me think more likely there's an abscess or there's some type of swelling that's obstructing into the laryngopharynx or oral cavity that's obstructing airflow. Another one is trismus. So trismus is not going to be super common in a patient who has a basic uncomplicated tonsillopharyngitis. It means that we have some kind of irritation of the masticator muscles, especially things like the pterygoids, which are very, very close in these spaces, like the peritonsillar and the parapharyngeal spaces. So difficulty with being able to open up the jaw or pain with that is a very common sign of deep neck infections like trismus, right? A muffled voice. We often hear the term a hot potato voice. It's just the way that whenever you have an obstructed laryngopharynx, what happens here is that whenever you have, and even oropharynx, so an obstructed oropharynx and laryngopharynx, whenever sound is supposed to resonate through those cavities, if you have an obstructive abscess or swelling in that area, it's affecting the resonance of the person's voice, and that's why it presents more muffled. You're not going to get that with a basic tonsillopharyngitis. You may have a hoarseness because the infection is maybe spread a little bit to the larynx, or you have postnasal drip or something of that nature, but it's not going to cause this degree of a muffled voice. Drooling or inability to swallow secretions. Think about this. If you have so much swelling in the oropharynx, laryngopharynx, it's going to impede the movement of that saliva, any kind of like secretions that you need to move down into the esophagus. That's going to pool. And the concern with that is that drooling or inability to properly swallow, maybe it's driven by pain, maybe it's driven by the actual swelling itself. This increases the risk of aspiration, and that's a concerning thing. Neck swelling and pain. Again, you can get neck swelling. It's usually anterior cervical lymphadenopathy that occurs with something like a strep throat. So neck swelling, you can get like an anterior cervical lymphadenopathy. You can get posterior cervical lymphadenopathy with mono, and that's definitely possible. But when it's a very, very enlarged and it's usually unilateral and it's significantly painful and maybe it's fluctuant, that makes you think more about an abscess or maybe even a Ludwig's angina than we think about potentially a basic tonsillopharyngitis, right? And last, but obviously pretty rare, hemodynamic instability. This is usually a patient who has something like a deep neck infection like a retroperitoneal abscess or a Ludwig's angina that is then spread to the mediastinum or spread to the actual bloodstream. They become bacteremic, or they've developed a necrotizing mediastinitis that puts them at a high risk for things like hypotension, tachycardia, which again is possible, but also relatively rare. I think the key thing I want you to take away from this, and this is, I think, really, really important when it comes to your exams. If a patient comes in with throat pain, and they come in with any of these red flag signs or any signs of airway compromise, and I want to emphasize more on the airway compromise point. You don't waste your time getting a CT scan. You don't waste your time getting in there and kind of looking at their oral cavity and things of that nature. If they are in respiratory distress, if they say, what is the most important next step in management? It is always monitoring and, if needing, securing the airway. Obviously, it's your ABCs. Monitor the airway, monitor their breathing. And if they have any concerning signs of an airway obstruction, they're not breathing properly, what is the next step? It might be oxygen support. Maybe that's a nasal cannula. Maybe that's high flow. Unfortunately, sometimes it may actually result in intubation, but the goal is not to wait too long to where that near total obstruction of the airway leads to you having to crike the patient, right? So airway, breathing, circulation, but make sure that you put emphasis on stabilizing the airway first before doing any kind of imaging or tests. All right, if you don't have any of these red flag signs, then you don't need to be worrying about an airway. That's when I would be thinking again, also, this isn't concerning for deep neck infections. This seems more like a tonsillopharyngitis that's viral, bacterial, mono, something of that nature. And we talked about that in that lecture, the throat infection. So go watch that if you guys need a little bit more of a reminder for that. But if you do have any of these red flag signs, that's when the discussion comes into play, which is, okay, I'm concerned that there might be a deep neck infection. So that's when I'm going to do a really, really good exam. Now, again, first thing that's most important is airway management. If I have a patient who is in respiratory distress, they have intercostal retractions, they're also having difficulty, they're breathing really, really fast, they're hypoxic, they're cyanotic, anything like that, I'm not going to look in their oral cavity until when I'm intubating them, and I'll get a good look. But airway comes first. All right. If you have a patient who's pretty stable and you have the opportunity to do that, that's when I would do a good oral exam. Take a look in, see if there's any kind of problems going on, and then look at the neck. Feel for lymphadenopathy. Look for any obvious swelling, whether it be unilateral, bilateral, etc. So let's say that we did a really good oral and neck exam. If I did that and I have something where there's swelling on the floor of the mouth and the tongue is being pushed upwards and maybe even a little bit posteriorly, that makes me start to think about something like Ludwig. So again, swelling on the floor of the mouth, usually it's red, maybe sometimes there's pus, and again, the tongue is pushed upwards and posteriorly, start to think Ludwig's. And then on top of that, Ludwig's, it's so restricted in its ability. It's a very, very nasty necrotizing cellulitis. It's not an abscess. When this thing actually causes an infection, it can't really spread because it's limited by the tongue and the floor of the mouth superiorly. And then it's also limited by the cervical fascia. And because of that, it really swells significantly. In their neck, they get a really, really bilaterally enlarged bull neck. And they kind of use this term, a woody induration. So if you take a look here, you can see this poor child. Its tongue is being pushed upwards and posteriorly. You can notice that the floor of the mouth is kind of swollen. This is an obvious airway obstruction issue. Can I intubate this patient? Probably not. And it's going to be really dangerous if I even try to. Oftentimes, and we'll talk about this a little bit later, we oftentimes have to go through the nasal cavity and we have to do like a nasotracheal fiber optic kind of like intubation process. And we'll get into that a little bit later. But this is really, really concerning. And then you can see the mouth, but then look at the neck. You see how the neck is kind of like uniformly swollen and it's almost like a bull neck type of appearance? That's concerning. And that would make me think about Ludwig angina, all right? And we talked about this. Usually it's due to some type of like odontogenic kind of process, like an infection, usually of the second or third kind of like tooth molar we talked about. All right, that's a clinical diagnosis. I don't need to get imaging to do Ludwig's. That's it. That's how I diagnose it, is based upon the clinical presentation and what I get off of my physical exam. Similarly to that, if I see that the tonsil on one side is really swollen, and so much so that it's pushing the uvula to the contralateral side. So take a look here. We can see on the right side, you can see that this is really, really fluctuant. It's swollen. It's tender, I bet you. And look what it's doing to the uvula. It's pushing it a little bit to the other side. So we have tonsillar swelling and uvular deviation to the contralateral side of where this inflammation is occurring. That's peritonsillar. And you can look at their neck, but they shouldn't have any kind of invading of space or deep neck space, which actually causes visible neck swelling. If we take a look here, it would be kind of a normal neck exam. I wouldn't have to worry about it. So it's primarily this finding, and that's what really screams a peritonsillar abscess. At this point, the diagnosis has been made. I don't need to get imaging. It's right there in front of me. Unless there's other concerning signs, because the problem is a peritonsillar abscess can spread to the parapharyngeal space. So if I am concerned that it did spread to that parapharyngeal space, by all means, I could do imaging. But in this scenario, it's pretty clear, cut, dry clinical diagnosis of a peritonsillar abscess. All right, we do this one. We do the oral exam. Sometimes you may see this, and here's the problem. It's kind of hard. So for example, you have tonsillar pillars, and usually there's an anterior and posterior tonsillar pillar. Peritonsillar abscesses, they kind of reside more within that anterior tonsillar pillar and recess, whereas parapharyngeal abscesses, they're usually more in the posterior tonsillar pillar and then behind that tonsillar pillar. So it may be hard to see these, but anytime you can see that the actual pharynx, not in this case, not the tonsils, not the tonsillar pillars, I'm talking the pharynx behind the tonsillar pillars, or at least the posterior tonsillar pillar being involved. If that is swollen and pushing the pharynx in medially, that would suggest a parapharyngeal abscess. I don't have any image to really show you that. But one is really, really clear is a neck exam. This is really one of the few that because of the space and the areas that it involves, it can actually cause a visible swelling right around the angle of the jaw, right? So right at the angle of the mandible, you can definitely see some swelling. So we can appreciate here, this patient has some pretty significant swelling here around that angle of the mandible. And so that neck swelling, and oftentimes, sometimes it can involve some of the other muscles like the sternocleidomastoid. It can kind of get and cause some inflammation, irritation of that one as well. It may cause things like torticollis, where their head is kind of tilted and twisted. And so that is something to consider. But again, look for some kind of mass inside of the oral cavity near that lateral pharyngeal wall behind, or at least involving the posterior tonsillar pillar, and a visible kind of swelling of that actual neck. That's usually the key, because again, there's different spaces as we talked about. There's an anterior and a posterior parapharyngeal space. And usually with these kinds of patients, that posterior kind of like parapharyngeal space causes more of that medial displacement, and that anterior parapharyngeal space is going to cause more particularly some of that swelling at that mass. And that's, I think, the key thing here. All right. So that would make me think about a parapharyngeal abscess. All right, so for the next component here, when we think about retropharyngeal abscesses, when we look in the oral cavity, what should we suspect? Well, the first thing is that posterior pharyngeal wall is going to be bulging more anteriorly. So if I took a look in this person's mouth here, whoa, you can see that there's a very, very large bulging of that posterior pharyngeal wall. So that'd be pretty concerning for potentially a retropharyngeal abscess. Now, neck exam, again, because of the retropharyngeal space, you're not going to see this kind of pushing outwards and causing any neck swelling because of the location of it. But one of the dangerous things about this is that because it's very close, again, it can move from the retropharyngeal space to the danger space, get to that prevertebral fascia, and irritate some of those prevertebral muscles, things like the longus colli. That puts it into spasm, and so they kind of flex their neck. Because their muscles are so tight and spasmed, they're going to not want to extend their neck, and they're going to refuse. And so that's really one of the key things. Also, when you agitate those muscles, you can cause them to contract and kind of contort you in a particular weird way called torticollis. And so those are definitely some things that I would want you guys to consider. So you can see, again, here's a young child with kind of like that neck stiffness, and you can see that there's some head tilting, that torticollis picture. So this would be kind of picture perfect for that retropharyngeal abscess. With truly these two, you want to consider a CT scan of the neck. Now, here's what I will tell you. In the exams, sometimes you may have a patient that has some kind of issue where they're having difficulty with, again, that swelling of the posterior portion of the pharynx that can cause difficulty with breathing. They may have difficulty where they're extending their neck, and they may end up getting a neck x-ray. That is not the gold standard. It can be done, but it's not the primary reason why you do it. A CT is the gold standard. So you may see sometimes where a patient gets like a lateral neck x-ray, and you'll see, look how widened these prevertebral tissues are. That's definitely evidence of a lot of inflammation and likely a pus collection. But again, that is not the gold standard. So that's the definitive way of kind of going about these. When you do it, it's going to be clear as day. If I see a hypodense, which is a dark collection on the CT scan, and the rim around it is really kind of bright, that's the contrast enhancing the abscess. And if it's in the parapharyngeal space, look, you can see it right here, guys. This is a right parapharyngeal abscess. You can see how it's kind of dark. You can see the rim is a little bit enhanced, like a whitish color, or that hyperdense type of appearance. That is an indication that this is a parapharyngeal abscess. Now, if I looked on the other scenario here where that same kind of like presentation was within the retropharyngeal space, and this one's super large, and it's almost like multiloculated if you think about it. This one has a significant amount, and it's causing a lot of like movement here. And really, this is the one that you get super concerned about. With retropharyngeal abscesses, they can cause a lot of mass effect where you need to be concerned about airway, but also these things can spread, as we talked about, into the danger space. And when they get into the danger space, retropharyngeal abscesses can cause acute necrotizing descending mediastinitis, which can be life-threatening. So that's why it's really crucial. And sometimes they may even extend that neck image. If we have any concern or even thinking about looking for it, we can say, how far is this extended? We can get a little image of the chest to see if this is extended down into the mediastinum, because that would be the definitive way. All right. One thing I want to say is that we don't have to get like, in other words, a lot of the times we want to know what is the bacteria, what is the pathogen that is causing this, and cultures are one of the best way of doing that, right? Blood cultures, I think, are always beneficial if you have a concern that the patient is getting septic, or you have any kind of fear of that. That's never a bad thing. But the best thing is getting a culture at where the actual source is. And source control is the key here. So whenever you're going to attack these abscesses, especially peritonsillar, you're going to be INDing it, or you're going to be aspirating it. When you do those things, the actual sample from that aspirate or drainage should be sent off to the lab to figure out what pathogen comes back, so that it can guide your antibiotic decision. But usually that's done while you're actually surgically aspirating or draining that abscess. All right, cool. I think that really gives us an understanding here. Again, what I want you to take away from it is a patient who presents with throat pain doesn't have to be all these things. It can just be tonsillopharyngitis. It's just, do they have any concerning features that make you think that it could be really more of a deeper infection that's spread from tonsillopharyngitis? If it is, go down this path. If it's not, go down this path, and we talked about it in a separate lecture. Really, the exam is key for these two, but it also helps us with this. X-rays are not a bad thing for retropharyngeal abscess, but you're probably getting it for other reasons besides suspicion of a retropharyngeal abscess. Really, these have to be these have to be definitively diagnosed with a CT scan for best resolution. And you'll see why in a little bit later. Surgical planning. It comes into play looking at, hey, where is this abscess with relationship to the C3 vertebrae? Where is this abscess with relationship to the carotid sheath? And that comes into decision making of how you're going to drain and approach it. With that being said, let's talk about treatment. How do we treat these deep neck infections? It's pretty standard across the board. If you wanted just a generic way of thinking about this, my friends, it's really antibiotics. And really with these, there's many different options. I think a lot of the guidelines suggest ampicillin sulbactam. And the reason why is a lot of these infections are polymicrobial. They can have some gram positive, right? They can have some gram negative. But I think the other thing is that they have anaerobes. And so really you want to have that broad coverage, right? You want to be able to cover things like Streptococcus pyogenes. You want to be able to cover any kind of anaerobes and methicillin sensitive Staphylococcus aureus. And so that's where ampicillin sulbactam really gives you that coverage. And it's generally an IV medication, because if someone's having difficulty swallowing and all of these different problems, IV, not only does it get you that dose that you need right away, but it also bypasses that painful process of the oral cavity itself. I think the other key thing that has to go along with this is source control. You got to drain the abscess. Now, that doesn't mean every single person gets the abscess drained. A good chunk of them usually have to get it drained because of the size, because of the location, because of all of the problems that come with it. And we'll get into that. But across the board, if you wanted a one-word thing, it's IV ampicillin sulbactam plus an abscess drainage. There is other antibiotics. You can use things like penicillin and metronidazole. You can use all these different types, but I think across the board, you'll see more likely than not, IV ampicillin sulbactam is usually going to be the standard way to go about this one. All right. So any deep neck infection, I think, is always crucial. We talked about this. Airway is king, my friends. If a patient is showing signs of airway obstruction, the first way that I want to try to manage this is assessing, okay, what is the key thing here? With peritonsillar, it's probably not often that you're going to have to tube a patient or do anything like that. Parapharyngeal and I'd say retropharyngeal carry a pretty high risk of airway obstruction. So you have to always be prepared for that. If there is significant airway obstruction to the point where you're worried about it getting so large that you're going to be too late and you have to emergently do a crike, if they're showing respiratory distress, if there's significant signs of stridor, hypoxia, then yes, you need to escalate your therapy to maybe a standard endotracheal tube intubation. Where I'd say that doesn't always apply is in certain case scenarios. And you'll kind of understand it as we go through this. Let's say when you're intubating a patient, obviously your goal is to be able to use a laryngoscope to be able to get you some space and run that cuffed endotracheal tube into the airway. But it has to run through the pharynx. If the pharynx is significantly swollen, okay, you might have to use things like a bougie. You might have to also kind of like get a smaller tube. But the goal is you're trying to get this in before it gets so swollen that it's too late that you have to go to the emergency option, which is to bypass that and crike them. So that's why early airway management is better than late. What is key is, what if I have a patient with Ludwig's where their tongue is so swollen and I just don't have space, and if I just accidentally tap the tongue or I kind of get anywhere near where this inflammation is going to trigger pain, and it's going to obstruct the airway more, and it's going to cause the patient to rapidly deteriorate. Ludwig angina probably wouldn't be best for this one. The other thing is that if I lose my muscular tone, that's probably the only thing. If I lose the muscular tone of the pharynx, that's going to cause the pharynx to want to collapse a little bit more. So in high risk parapharyngeal retropharyngeal abscesses, where I'm talking the airway is so small and there's very little room for error. If I take away the muscle tone by paralyzing them and sedating them, which is what your standard RSI intubation would be, the airway will get smaller, and I'll lose the one thing that's keeping that airway almost somewhat patent, which is their muscle tone. If I take that away, it's going to be even harder to intubate them. And it's almost impossible sometimes with Ludwig's. So in Ludwig's and in your high risk patients, you may need to do an awake intubation where you don't give them those things like sedation and paralytics so that you can maintain the tone and you can see where you're going. And oftentimes it's a fiber optic kind of process where we're going to run down where? We're going to start through the nose and we're going to run this thing down so we can see what we can see. And then what we'll do is we'll guide that endotracheal tube along the way to be able to secure that patient's airway. All right, that is really the key thing here. And that's what I want you guys to see is as we would do this, we would get a visualization of the epiglottis, we would get a visualization of the vocal cords, and we would say, oh, there we go, there's my cords, I can pass my endotracheal tube properly through there and not pass it somewhere where it doesn't belong. So you're getting a direct visualization that's going to guide your tube where you want it to go. And it's also going to be helpful because you're maintaining the muscle tone in this process to give you a little bit of a patent airway. All right. The reason why we do all of this earlier rather than later is this. You do not want to have to crike somebody if you don't have to. So, when you do this, you're literally doing a surgical procedure where you're making an incision between the cricoid and the thyroid cartilage. And when you do that, you then have to pass a tube through that little incision site. And it's pretty intense, and you just don't ever want to have to do that. And this is what happens if it gets to the point where you've waited too long or you've tried multiple attempts at a standard endotracheal tube intubation, and then you're stuck with this because, hey, if I don't, the patient is not going to have an airway. They're going to become hypoxic. They're going to go into cardiac arrest. And so we want to try to avoid this at all costs. That's why the first step in management for all of these patients is airway first, and then get into your steps of antibiotics and aspiration, et cetera, et cetera, et cetera. So once we've secured the airway, IV ampicillin and sulbactam is our go-to, right? Again, I think clindamycin is an alternative for those penicillin allergics. And again, I told you that penicillin and metronidazole is another option for ampicillin and sulbactam as well. But again, I want you to try to remember this one as the primary one. You're going to give that for all of them because it's going to cover most of those types of pathogens that you're most likely to see. All right, especially the anaerobes and your group A strep coverage. With that, with peritonsillar abscesses, all of these you should pretty much drain. And these ones are just, it's easier for you to, a lot of these are done in the emergency department. And that's kind of one of the things here is you can do this two different ways. The only time you probably might not do it if it's like super, super, super small, like less than a centimeter. But again, you would have to probably get imaging to really kind of size that out. So oftentimes these are just usually drained more often than not. So for the most part, we're doing needle aspiration and INDs on these patients. And so it's a simple thing. You're kind of taking a look here. We see that this is the area that I want to target. I can do it two ways. One is I can stick a needle in there and then pull back and then kind of suction out any of those areas there. Or another option is I can cut it, allow for it to drain, suction all of that out to make sure that I allow for good source control. So I'm letting the antibiotics do their job, but I'm alleviating the effects of the abscess and getting good source control right away. So that's really the goal of this one. And that's pretty much going to be standard across the board for peritonsillar. Parapharyngeal and retropharyngeal, if you really want to be specific about these, they don't carry that same standardized thing. You could always, in a general blanket term, say, draining them. Yes. I think it comes down to specific scenarios, and that's what we're going to talk about. But again, I think this is an important note to take away from this. Anytime, again, we're going back to this, when we're kind of when we're going in, we're actually kind of draining this abscess. Usually, for example, if you're doing a needle aspiration, you can kind of take a sample. But for example, I'd say if you're INDing it, taking a little swab, sticking it into the abscess, getting a little bit of that on that, and sending it off to the lab to identify, again, hey, what kind of pathogen do we got? Because it's going to help me eventually. I can't keep them on IV ampicillin and sulbactam forever. I want to get them on oral antibiotics. And obviously, there's empiric oral antibiotics that we could think about that would cover all of them, but we don't know if people are resistant and we don't know what kind of bacteria that they have. We want to make sure that we always have them on the specific antibiotic with the least amount of resistance. So that's the key. All right. The next thing is if I do have a parapharyngeal abscess, or if I have Ludwig's angina, or if I have something like a retropharyngeal abscess, those are, again, I think times when you have to ask yourself the question, I already got them on antibiotics, I've secured their airway. Do I need to do an abscess drainage? It's not always. And I think the general indications that come across, they're super, super obvious. It's all about the airway. If I'm going to put someone on antibiotics, right, and that can take care of it, good. But if I have an airway issue, and this is really becoming super problematic where I have to intubate them and I'm going to keep them on antibiotics, that means I have to give those antibiotics enough time to get that abscess down enough and the swelling down enough that eventually I can take the tube out. And so it really comes down to, is it affecting their airway? And that's really what you'll notice. For example, if the abscess is really large, why would that be a problem? Because if it's super large, it's going to cause airway obstruction or mass effect to other really critical structures. We got to drain those. That's common sense. If they're septic, that means that they're literally septic. This is continuing to seed the bloodstream. Get that dang thing out of there. Sepsis can be treated with all the antibiotics in the world, but if you don't got source control, it's not going to change anything. Airway obstruction. If it's causing airway obstruction, they have to be intubated. How am I going to get the tube out if I don't have an improved airway? All right. The next thing is mediastinitis. If this thing has actually spread, we got to make sure that it doesn't keep, because the problem with retropharyngeal abscesses is it's all based upon pressure changes and gravity. That thing will, if you have a retropharyngeal abscess, it'll continue to drain based upon changes in the intrathoracic pressure and what? Just gravity down into the mediastinum. And so if I don't get source control of where the mediastinitis is actually coming from, it's going to continue to occur and I'm not going to get better. So mediastinitis, sepsis, airway obstruction, all things that we talked about are true legitimate complications of these kinds of conditions like deep neck infections. And the last one is your trialed antibiotics. You said, I want to try and give them a little trial, maybe 2 days of antibiotics, see if they get better. These patients are usually being observed in the hospital. So this is an opportunity to put them on the antibiotics, monitor their airway, make sure that we're not missing anything and see if they get better. If they don't get better, okay, we don't want to waste time. Let's go ahead and get this thing drained. And that's what we'll do. Now, I think that's pretty self-explanatory. The next part is maybe a little nuanced when it comes to more surgical decision-making, so you can feel free to tune out at this point if you want. I thought it was kind of interesting when it comes to surgical decision-making. Retropharyngeal abscesses, because of their position, when you think about this with the relationship of the C3 vertebrae, it gives you an idea if it's going to be an abscess that's in view when you look in the oral cavity or out of view. And that comes into play of how safe it is to do a procedure transorally, or you have to go externally through the neck to get to it. So for example, if the retropharyngeal abscess is what? Let's say for example here above. Well, that means I can actually see it. It wouldn't be below like the tongue or behind the tongue. It's where I couldn't actually kind of safely go back there, cut and drain. So for that one, if it's above, I'll be able to see it. I could do a transoral IND. The other concept here is with this is you can, again, aspiration, but a lot of the times it's usually going to be, you're going to IND this thing. You're going to take a scalpel, you're going to cut it, you're going to let it drain, and you're going to suction that out, right? If you have a parapharyngeal abscess, you need to know when you look at it on the image, and that's why we get that IV contrast to really get a good look at the actual vascular structures in the carotid sheath, is where is it with respect to the carotid sheath? Is the parapharyngeal abscess medial to the carotid sheath or lateral to the carotid sheath? If it's medial, I can probably get to that because if you think about it, medial would mean I could probably attack that from the oral cavity. If it's lateral, that means I got to go through the carotid sheath to get to it. That's dangerous, dude. So medial to the carotid sheath, I could get to it potentially, right? But then we go to the other option. In that scenario where I would be able to do that, cool. But what if I had a patient who had a retropharyngeal abscess and it's below the C3 vertebrae? It's out of my view safely. I got to go externally. If it's lateral, I'm going to have to go through the dang carotid sheath to get to it. I got to go externally. And I hope that makes sense because with external INDs, you're literally opening up this kind of triangle of the neck to visualize things because I want to make sure that I'm not cutting something that I shouldn't be cutting. I want to make sure that I'm accessing an abscess safely and I'm not damaging any structures along the way. So that's the benefit of knowing this. And I just thought that that was kind of helpful to take away from this. Now, again, I think, a really, really important thing here is you're probably like, okay, we talked about retropharyngeal, we talked about parapharyngeal, but you didn't really assess more specifically. Yeah, you said the indication. So I get Ludwig angina, if there's airway obstruction, if there's sepsis, if there's I get it. But is there anything specific that I need to know about performing these surgeries? Would I do it transorally? Would I do it externally? These ones are not abscesses, so you're not really draining them. The only reason you're doing these is to decompress. So because of all that necrotizing infection and gas production and swelling, All you're really doing here is opening up an area to decompress and allow for space to come back within the oropharynx and laryngopharynx. That's really all you're doing in this scenario, is because if that is causing the airway obstruction, that significant amount of swelling and mass effect, decompress it, give space, and that's going to help that patient significantly where we don't have to kind of have them intubated for a long time. All right. So I think that's the true key thing here, is you're not doing any kind of like procedure per se on Ludwig angina to drain an abscess. They can get abscesses, but it's more of a necrotizing cellulitis that may give gas production, a lot of swelling. You're more focusing on externally decompressing so that you can alleviate that severe airway obstruction. Woo-wee! I think this kind of gives you a very perfect, not perfect, but I think a general picture as to how to approach deep neck infections and to think about them thoroughly. Don't just say, oh, you give them antibiotics and drain the abscess. Maybe take the second step to know again, when do I really focus on airway management? What are the antibiotics? Why am I giving these antibiotics? And then also, when do I drain? And if I drain these abscesses, how do I drain them? What's the approach? I think this just makes an overall better clinician. But man, I hope that you guys like this lecture as much as me and my team did making it, because we love this and we love helping you out. And if you guys are appreciating it and if you guys are learning a lot, let us know. You can do that by hitting the like button, comment down in the comment section, subscribing. If you guys want more information on these things, we provide quizzes, we provide flashcards, we provide notes on our website. So go check that out. But man, I love you guys. I thank you guys. And as always, until next time.